So we're often looking at treatment patterns in even sometimes large single center or multi-center studies that are often more tertiary or referral centers. This is zooming out and looking at a very high level in a Medicare fee-for-service database in patients thus over age of 65 to see what is the actual status quo, what are patients, how are patients being treated, and also importantly, what biomarker utilization looks like currently. This time frame was from 2020 through 2024, and what we found, looking at I think 21,000 patients, so really getting a sense of what the status is in the U.S. in what is the most common demographic for CLL. About 2/3 of patients are over the age of 65, so would be in the Medicare realm. The most commonly prescribed agent was fortunately one of our targeted drugs, BTK inhibitors. We also saw surprisingly and unfortunately that about 13% of people were still receiving chemoimmunotherapy. And then a larger group that also you can make the case as being undertreated certainly were patients receiving anti-CD20 monoclonal antibody therapy alone, so not in combination with a BTKI or a BCL2 inhibitor. So I think from a broad, one of the main takeaways from this study is still in 2020, 2024, certainly this includes peak COVID years, but those were times when particularly you'd want to be not giving chemotherapy or, even anti-CD20 perhaps would have been de-escalated, downgraded in your choice options. So there is a knowledge gap and unmet need that we need to, as a community, continue to try to get more of our patients, broadly speaking, people with CLL, onto the best therapies that are out there that we know have proven survival benefit, are more effective, better tolerated agents than chemo, and simply more effective than anti-CD20. And actually, colleagues at Mayo, in collaboration with a Danish group, have published even in age over 80 that patients in that age demographic did better with targeted agent drugs compared to CD20 alone. So really, it's all about fitness versus frailty, not age as a chronological number now. But these patients need to be getting the best therapy for them. Secondly is the biomarker utilization that we help kind of guide treatment selection in the contemporary era, and especially is stronger than I'm already trying to get the point across to avoid chemoimmunotherapy in patients with high-risk molecular features, unmutated IGHV status, deletion 17p. These numbers were really subpar. I mean, at large, there was quite a few patients who didn't have these tests performed at all prior to starting therapy, and that's again a miss. But this isn't putting this just all on the community, saying like, why aren't we doing these things? That's something that us as a hematology CLL community need to continue to advocate for, these being covered, so when people are ordering the tests, they can do it with confidence that the patient's not going to be left with a bill, or they're not going to get an extra phone call on this. But takeaways: large cohort, over 20,000 patients, most commonly prescribed drug in the age over 65, this Medicare population, was BTK inhibitors. It was also the group that had the most increase in prescriptions over that time, that was really driven by an increase in zanubrutinib use, a second generation BTKI, and then beyond that, there are still gaps where there are patient populations that aren't getting what is the preferred or best treatment for them. We need to get better there. We need to get better at the biomarker.